Welcome everyone. Good morning, good afternoon, depending on where you're at. Welcome to this webinar on COVID, the vaccines, and ALS. My name is Ken Menkhaus. I'm a professor of political science at Davidson College in North Carolina. I'm also a trustee on the ALS Association's National Board of Trustees, and I'm a person living with ALS. So like the rest of you, I'm very much a stakeholder in this conversation. This is a fast-moving topic. We've got new developments breaking every day about the status of supplies, vaccine distribution, COVID variants, and much, much more. There's a lot of questions out there about how, when, and where the vaccine will be available to people with ALS and their caregivers. Hopefully, this webinar will help answer those questions, and if not, we're just going to have to do another one. Today, we are joined by a distinguished panel of physicians and experts to break down this very fluid situation. First, Dr. Rick Bedlack is a physician and professor of neurology at Duke University and a director of the Duke ALS Clinic. He is a past chair of the North American ALS Research Group and leader of the International ALS Untangled program. Dr. Urvi Desai is director of the Carolinas MDA Care Center and professor of neurology at Atrium Health. She's been recognized as one of the most influential primary investigators within Atrium Health Neuroscience Clinic Research Division and has expanded its neuromuscular research portfolio in ALS. Dr. Desai has led a research team in the conception, development, and launch of the only COVID-19 registry for ALS patients in partnership with the CDC, and has reached out now to more than 10,000 ALS patients in the US. If you're keeping score so far, that's North Carolina 3, the rest of you 0. We're waiting. All right, here's some others. Dr. Marinella Gallia is chair of the Spinal Cord Injury and Disorder Department and director of the ALS Clinic at the James J. Peters Veterans Administration Medical Center in New York. She is an assistant professor of physical medicine and rehabilitation at the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai. Since 2017, she is a member of the VHA ALS Executive Committee, which provides clinical, educational, and research guidance in support of strategic planning, national initiatives, and professional practice for veterans with ALS. Dr. Lou Libby is a pulmonologist who serves with me as a trustee on the ALS Association's National Board of Trustees. He's also a founding member of the board of the Oregon Southwest Washington chapter of the ALS Association, and Dr. Libby is associated with the Providence ALS Center in Portland, Oregon. Dr. Cherise Laura Allegrini is an epidemiologist and the chief executive officer at San Antonio AIDS Foundation. She's the former research director for the Immunization Partnership. She previously served as a pandemic flu coordinator for the San Antonio Metro Health District in the public health emergency preparation. And Dr. Neil Thakur is also an epidemiologist, but he's better known to this audience as the chief mission officer at the ALS Association, where he leads the association's research, care services, and public policy activities. It's a very distinguished group. We hope to take full advantage of all of you, and now let's get right to it. I'd like to start with what we know about COVID-19 and ALS, the state-of-the-art knowledge about how COVID-19 attacks the respiratory functions and what that means for those of us living with ALS. Some specific questions. What do we now know about the epidemiology of COVID? What do we know about risk factors for vulnerable populations, particularly those in healthcare or residential facilities? Do we now have, or are we collecting good data indicating whether COVID has particular or lasting impact on progression or complications with people living with ALS? And are you seeing people, for those of you who are in clinics, are you seeing people with ALS who have had COVID? And what are we learning from those cases? The floor is open. Dr. Bedlack?
Yeah, this is Rick Bedlack here at Duke. Appreciate the invitation to be with you all. I wanted to just talk a little bit about risks. So, in my opinion, there's 4 different ways to look at the risks of the pandemic and the virus itself for people with ALS. First, I think there's psychological risks. ALS is already an isolating disease for patients and families, and now the need for social distancing over the past year has made this even worse. Many of my own patients have been unable to see their extended families or spend important days together like holidays, weddings, birthdays, etc. So not surprisingly, I've seen increased levels of depression and anxiety in my patients this year. Second, the pandemic has forced the closure of many multidisciplinary ALS clinics and PFT labs. And this means there's a potential that the disease is not being diagnosed as quickly or being followed as carefully by expert clinicians. Third, I personally believe that people with ALS are at an increased risk of getting COVID because often they can't completely isolate. They need things like home health aides, home PT, home OT, and equipment vendors. These things are important in terms of optimizing the quality of their life, and that means people who are potentially infected coming in and out of the homes. And finally, and maybe sort of most importantly, I believe people with ALS are at an increased risk of a bad outcome from getting COVID infection. So we know that having pulmonary problems or cognitive impairment increases the risk of a bad outcome from COVID. And many people with ALS have these. You asked earlier about the effects on the lungs, and I think Lou will take that on, but it's really shocking to see the neuroinflammation that we now know COVID can cause. And neuroinflammation is believed to be part of the pathophysiology of ALS. And so theoretically, by ramping up neuroinflammation, a COVID infection could make the disease progress faster. And I hate to say it, but over the past year, I've had 9 of my own patients get COVID infections. 2 of them were doing extremely well, progressing very slowly before the infection, and both of them have had a marked acceleration of their progression during and after their COVID infection.
Thank you, Dr. Bedlak. Are there others? You referenced Dr. Libby for issues related to pulmonology. Dr. Libby, you want to add?
Sure, I'd be glad to comment about the pulmonary effects of COVID infection in ALS patients. And I have seen 4 patients in our center who have experienced COVID infection and recovered. We've had none die. And fortunately, they have not had long-term poor outcomes. Only one of them was hospitalized, so we were fortunate. But I totally agree with Dr. Bedlak that ALS puts our patients at very high risk for poor outcomes. As far as the respiratory effects of the COVID virus, it's the major effect that, as a pulmonologist, I obviously worry about and most patients experience. Many patients simply have either no symptoms, maybe as many as half the people who have COVID have no symptoms and never develop symptoms, but many have sniffles and a cold, nothing unusual, and they get over that fine. But a small percentage, maybe 10 to 20%, develop a pneumonia-like situation. And what happens is the virus usually gets into our nose, our mouth, maybe our eyes from droplet transmission. It gets into the cells and is replicated in the cells. And then the cells die, but there's enough of the virus that gets into the bloodstream that it goes many places in the body and frequently, if not always, into the lung. And in the lung, the same sort of thing happens, and our immune system begins to fight off the virus. If we're lucky and the immune system is quick, it overcomes the virus and it goes away, and the pneumonia may need no treatment. But in maybe 5% of patients, they end up in the hospital because of the pneumonia, the inflammation, and the destruction of the cells is so severe that oxygen is not getting into the blood adequately, and that's when people end up in the hospital. And if it's really severe, they need to be on a ventilator to breathe for them. Or if it's even more severe, we may go to the point of putting them on a machine called an ECMO machine, which takes all the blood out of the body, puts oxygen into it, and puts it back into the body while the lungs recover. So that's roughly what happens in the lungs. And fortunately, only 5% of patients or so get severe enough disease that they need to be in the hospital, and roughly 1% die. The patients who do end up on a ventilator have a much higher rate of death, and that's probably in the order of 20 to 30% now, down from 40 or 50% early in the pandemic because we've gotten better at treating the disease. But ALS patients, because especially if they have weak breathing muscles, and you would know you have weak breathing muscles if your testing is considered low, or if it's low enough that they've put you on some sort of breathing machine to support your breathing. If it's that low, you certainly are at higher risk for pulmonary complications and ending up in the hospital. And we hope we can avoid that with these vaccines.
Thank you, Dr. Libby. Dr. Desai, if I could direct the question your way. Dr. Bedlak had some worrisome anecdotes from his clinic. You've established a registry now which can take those anecdotes and collect enough of them to create data that's statistically significant. And of course, that's going to be critical if in fact this is a worrisome trend among people with ALS. It's going to be critical as evidence to convince state and local authorities to prioritize us for access to the vaccine. What do we have so far?
Absolutely. And so what we have been feeling quite early on is that we are dealing with very fragile and very specific patient population where we have to be so upfront to understand what is the potential of this disease. And we still don't know so many things about disease. We had been looking at this issue quite early on, and so we decided that why don't we scientifically study what happens if indeed our ALS patient do tend to develop COVID. And so we created a registry, and we will share with you some of those rationale and methodology of this registry. Can we go to the next slide if it is available? Okay.
Give me a moment. I'm having a little technical problem here. Please go ahead and I'll call the slide up. Thank you.
No problem. So what we did was it was a conception that at our ALS clinic, we felt that this is something we really need to look into. And so we decided that why don't we create a patient-facing registry, meaning that the patients who develop COVID, ALS patients, would enter some data in this registry. And so it is kind of something that takes around 15 to 20 minutes. And that was mainly because we just have no information regarding what happens in ALS patients if they tend to develop COVID-19 infection. Also, Dr. Libby and Dr. Bedlak just pointed out quite nicely is that there is so much of overlap of respiratory involvement in both diseases, and we know that the most common cause of death in ALS is respiratory failure. So we definitely wanted to see if indeed there is any change or there is any specific impact on the respiratory function. And so let's go to the next slide. And so what we decided is that not only what could be the potential incidence and prevalence of COVID-19 in ALS patient, but also look at the disease trajectory. And Dr. Bedlak just mentioned about his experience with a couple of patients and how the slow progression changed into something different. So that is something very important for us to look at. And so what we decided is to ask patients about their basic diagnosis, in addition to, of course, demographics data is, we are all aware of the ALS-FRS scales that is performed in the ALS clinic. So we ask those questions, try to understand what is the baseline that these patients had before getting the COVID infection, what treatment they had been on, and if indeed, for example, if they were on riluzole or edaravone, etc., would there be any impact of these medications in a positive or a negative way as we look further. And then what we decided is that if the patient recovered, a month later, they would come back and give us some more data regarding their status of health, especially again going back to the ALS-FRS scales. And unfortunately, if someone has died, we would also like to get that information. So this is the whole aim of the registry. So far, let's go to the next page. So far, actually, we don't have a lot of data. We saw that we have 13 entries, out of which 8 were screen failed because they were only ALS, and we had 5 patients who had ALS and COVID. Out of that, 4 have recovered. There were no deaths so far that we have seen. And there's one patient who is not yet a month after, so we are waiting for them to fill out the further information. Out of this, 4 patients have been on Riluzole, none had been on Radicava, and 1 on Nuedexta. So it is too early for me to share anything beyond this, because we will definitely need to do a lot more calculations to understand. But I am very excited about the potential of this registry that can provide us some information down the road and make us more preemptive in how we care for these patients, help us create some care guidelines, and hopefully we can take this more internationally, as there is an Italian registry data collection going on. So hopefully we can try to combine the data and have more information as we go forward.
Thank you very much. A follow-up question: are there any plans to create a registry of people living with ALS who have had the vaccine to monitor what effect or impact, positive, negative, or null hypothesis that might have down the road?
Yeah, no, I think just a couple of days ago, actually, this question was brought up, and we are going to look into that. I think that is a very important question, and we can see if we can piggyback on our registry where we can ask patients the same question. We had a tremendous support from CDC. They have been able to, the CDC has a huge ALS registry, and they have been able to send this information to more than 10,000 patients. We are in the process of having some communication with NILS at consortium, so we'll reach out to those centers. So we think that we are equipped to get into this question in more detail, and we definitely will think about it and see how we can materialize that.
Thank you so much. Any other comments from the panel before we move on to the next question, Dr. Bedlak?
Yeah, so Dr. Desai, I want to congratulate you on putting this together. I wish I had started it right in the beginning of the pandemic. And it sounds like you're doing a lot of good things to try to create, more awareness of this. I myself didn't know about it until a couple of days ago. So maybe sending out information to all the NILS investigators that you're doing this so we could pass it along to our patients. I think it was a great idea to use the National Registry's research notification tool. I found that to be a very powerful way to boost enrollment in a lot of my own studies. But of course, there is one thing to be aware of with your registry, and that is, being that it's patient facing, there's always going to be some bias there, some selection bias. It may be that people who die from COVID, you don't ever hear from their families. It may be that people who have very mild infections, you don't ever go and put anything in there. So I think it's going to be a really important tool. I definitely want to encourage you, and I want to try to help you as much as I can. But I also like the tool that Dr. Galea is putting together, because that actually doesn't require any input from people. It's actually, we're searching within a database, the VA database, and finding ICD-9 codes that allow us to, actively rather than passively bring people into the registry.
Dr. Galea?
Sure. So first of all, it's a pleasure to be here. I'm so happy to share some of the information that we have gathered at the VA. I'm a VA doctor, as mentioned, and so proud to be one of those. And as such, as you know, you probably all know that our veterans are men and women who serve in the military service in the US have an increased risk for ALS. And of those, we know about 4,000 veterans are receiving care benefits in VA, either through the health administration or to the benefit administration. And of those, about 1,400 receive care at the SCID center. That's how I come into play. That's where I work, at the Bronx VA Spinal Cord Injury and Disorder Center. Now, I'm not gonna dwell much longer on the risk that ALS veterans and PALS have for develop COVID and serious consequences of the COVID-19 infection. I just wanted to add a little bit to what Dr. Bedlak already said. So what we notice is that it's really difficult for someone with a disability, looking at that from the physiatrist point of view, to be able to maintain safety measure, wash their hands, keep distance with others, do not touch the wheelchair, do not touch anything. So these, when we talk, do follow the guidelines, that's not easy for someone with a disability. Additionally, having been in the thick of the pandemic in the early spring in the Bronx, I know that we had PPE sufficient just for us at the center. We had difficulty sending them out to the field, to our outpatients. So having access to gloves, to gowns is really important and may not be as easy for someone with ALS. And additionally, what we've seen lately, as there was a mention about Riluzole and Edaravone, we've seen a lot of delays with shipments of medication and supplies, especially starting December, just because of the lengthy, the delay of the postal service. So everybody knows, or if you don't know now, you know, the VA is a data-driven system. We are rich in data and information. And we do that because we really want to make sure that we know a lot about our veterans and we can properly take care of them. So there are a couple of projects going on in Big VA regarding COVID. One is the index mortality, so is a basically site where there is a calculator that gives us an idea of the risk that someone might have to develop COVID-19 and die from it. And then there is also a report which is publicly available that shows how many veterans were found to be positive, how many died of it, how many recovered. Now, in terms of our own SCI and disorder system, we have developed additional reports based on the data. And one of the main reasons why we are looking at that and I'm here today is because we thought it was important in emergency response or in case of such a pandemic to be able to know where our patients are, what happened to them, what kind of comorbidities they have, and so forth. So we have developed an SCI COVID-19 summary report, which identify our veterans through laboratory testing. Now, the test could have been done at the VA or outside the VA, but just enough for us to see proof and document it in the electronic medical record. So the test could be a PCR test, an antigen test, or an antibody test. As far as it's there, we can find it, collect it, and analyze it. Based on that, we can see who's positive, so who's active, so meaning actually infectious, or convalescent, so they had the COVID and recovered, or, you know, clearly pending data, we don't know what's happening, we're just waiting for the result to come up, or negative. Now, the good thing about it, the very interesting thing, which is really intriguing and I think is going to help us to understand better who's a higher risk and you know, push forward with allowing more people, more ALS people to receive the vaccine, is also that this database also give information about related risks. Who was on a non-invasive ventilation, who had a caregiver, who had diabetes, and so forth. So we're in the process of analyzing this data, so I don't have the whole report for you. But one of the things I wanted to share with you today is, I hope you can see that. So this is a chart comparison between the big VA population, and I mentioned before, data is publicly available. And you can see there were about 200,000 positive cases in the general veteran population, with 11,000 active cases, and about 184,000 convalescents, so people who got the infection and recovered. And of those, about 8,800 passed. So give us about a 4.6% case fatality rate, people who did not survive. Now, we have now to look at our smaller population, right? And if you look at that, we tested about 700 of our veterans with ALS, and of those, 63 tested positive, 4 are actives, 51 are convalescent, and 8 passed. So based on, again, small numbers, the case fatality rate that you see is much higher than the one of the general population. So some of the things that, first I wanted to bring up some of the limitation. Again, this is a subset of veterans with motor neuron disorders. So just so you understand, when we say ALS, 95% of the veterans who have motor neuron disorder in VA have ALS. Of those, as I mentioned, we take care of about 4,000. Of those 4,000, 1,400 follow the STI centers. We were able to test about 700 of those. So again, it's a subset of veterans. Additionally, I'm sure there are other non-VA deaths that need still to be reported. The VA requires for a death certificate to be sent and logged into our system to certify that someone died of something. So sometimes the delay is 3 to 6 months, even more with this pandemic. And finally, you know, the mortality rate is important because we wanna make sure, we wanna see how was the mortality last year compared to this year. And again, this is something we're still analyzing. What I wanted to share with you briefly, if I have a minute, is that of those small subset of patients who passed, they were all on non-invasive ventilation, on BiPAP. Specifically, one of those, who was a patient I was following, had a typical symptom. He had profuse diarrhea. And now, one of the things that was surprising is that some of the feature of ALS, as you know, is constipation. So the family kept giving him medication to allow him to move his bowels, and they didn't realize that while they were doing that, the patient was getting sicker and sicker. So by the time we saw him and we tested him, he tested positive and finally passed. So again, a presentation that may not be the typical presentation of somebody developing a respiratory infection, but something different. So to be on the outlook for that. Wanted to add also that one of the about 25% of those who died had diabetes, which is one of the comorbidities associated with COVID death in the general population. And also, interesting enough, we're looking at the BMI, which was about 25. And as you know, being overweight and obese is a risk factor for dying of COVID-19. Usually it's not the case in our population because we encourage our patients to eat more, they lose weight, right? Finally, although in the general positive cases that we had, there is always a premises. There is always a prevalence of white in terms of race versus African American in our ALS population for whatever reason. But when we talk about the death, there is a much higher death rate in African American than the white compared to the one who survived. And the final thought, the one who survived had a tobacco history use of about 6%, so they were very small percentage of those who were smokers, while of the one who died, about 13% were smokers. So smoking, we know it's not a good thing, right? But really helped, did not help in terms of survival. Finally, we're looking at data about the ALS functional rating score, which we're gonna have soon. And also we are collecting data on who received the vaccine. In VA, for those who don't know, the vaccine is available for everybody, all the veterans 65 years or older, and VA. We really are pushing to try to be able to administer that to all our ALS patients. So.
Thank you so much, Dr. Gallia. I'm going to turn our attention now to the next question, which has to do with vaccine distribution and access. It's a major preoccupation for all of us. What is the current state of distribution and availability for people with ALS? Basically, where are we in the queue and why are we in that part of the queue? Why is the plan for COVID vaccination distribution seemingly so complex, especially for vulnerable populations? Is there any recognition at the state or federal level of the urgency of getting caregivers vaccinated at the same time? And then finally, what do we as people with ALS need to be able to bring to the registration process that determines our eligibility to prove that we are in the category that that is now eligible for access? I myself went ahead and just got a letter from my clinic explaining that I have ALS and explaining what ALS is, thinking I might need that when I get in line. Is that necessary, or are there other things that we need to have prepared for so that we can get access when it's our turn? Who'd like to go first?
This is Sharice Allegrini. I'm happy to jump in on that. It's something I've been working on a lot locally. And the first thing to say is that it varies from state to state and city to city. That's one of the challenges. So let me back up and say that our system is incredibly decentralized, and while that's often a good thing for public health because we know our communities, we want to work directly with our communities, in terms of the vaccine rollout, the lack of centralization has meant that it varies so much from place to place. So there's not one answer. It's a huge challenge everywhere. And what I'll say is keep in mind that while ALS has not been put on the priority list, unfortunately, and we can get to that later, there's other comorbidities that are on the list, as well as being over 65. So it's quite possible that you have folks who have ALS but have other issues such as obesity, diabetes, heart disease, and there's a few others that would put you into the priority category to start. And so if you're eligible for one of those, start with those because you're on the list now, and don't wait for ALS. We'll work on trying to get ALS on the list also. But the other thing is you asked about proof. I can't speak to all communities across the country. And again, some states are very strict about it, some are less so. I can tell you about my local community in San Antonio. No, they're not asking for proof. It's an honor system. Now, if you're going through your healthcare provider has your information already. And one way of distribution is through the healthcare provider. The city distribution, which is sort of the mass vaccination clinic for the eligible folks, they just ask you why you're eligible and note that down. They're not going into details. Other places are asking for documentation. Certainly it would not hurt to have that. But again, it's going to vary from place to place. And I'm happy to answer all the other questions, but I can let someone else jump in, or you can remind me what the questions are.
Thank you. Let's for the moment, we'll open the floor to others about various aspects of distribution and access. Dr. Libby? Dr. Libby, you're muted.
Now I'm not muted. I'm back with you. So thank you. I would certainly reemphasize that we are decentralized not only to the state level, but even to the county level. In my state, Oregon, is different than many other states. We are prioritizing educators before elderly, and the elderly before people with chronic diseases. Whereas Washington, which is 5 miles away, the state of Washington, does the elderly first. One thing, I have spoken to our local state health authority about ALS and being on the list of at-risk diseases, and they've reassured me, and I've also heard a webinar from that ALS participated in with NORD, the National Organization of Rare Diseases. They had the CDC vaccine expert, Dr. Amanda Cohn, and she reassured everyone on that phone call that the rare diseases, including ALS, although they are not on the list of at-risk diseases, will be considered risk diseases. It's not on the list because there's not enough people with all these rare diseases to be on the list. If you have hypertension, if you've had heart disease, if you've had cancer, those are common, so they get on the list. They just don't have the data yet to prove that ALS is a risk, but everyone knows it's a risk disease. So don't be swayed by that. Consider yourself at risk. And my state is also moving towards the confirmation of at risk. And anyone with ALS, I consider at risk. I'll leave it there for others to mention.
Yeah, I'd like to add to that, Dr. Libby. So just so you all know what we've been working on in the past, So in December, our chapters sent letters to the state governors reminding them that ALS is a high-risk condition. And I think part of the challenge here is, as Dr. Libby was saying, is there are literally thousands of diseases that could fit into the criteria. And so for it to get in that top level is very challenging. But we were able to also make happen in December, I think actually through the staff of the National Registry, is to have ALS included under the category it might be an increased risk for severe illness from the virus that causes COVID-19, which is a second level layer of risk. It's not the same as the diabetes category where we have lots and lots and lots of experience, but you've seen as much data, I think, as anyone has seen right now, the outcomes for people with ALS who have COVID. We just know very little. So that's where we are. And I think to Dr. Libby's point, you're not going to see ALS on any top level list because there's no room for it, but that doesn't mean we shouldn't just say, look, it's a serious disease, it's a serious risk, and we qualify. And I'd love to hear more from the other panelists about that strategy.
Thank you, Dr. Thakur. Others? Dr.
I would add that, as Dr. Thakur said, that we don't have a lot of data, but we do have some data. And so while the numbers aren't high, we know that of people with ALS, they're more likely to have severe complications with COVID. You can use those numbers to make an argument, even though, again, it's a rare disease. And again, one thing that might help is looking at, how many doses does this really mean if we put ALS on the list? It's not that many doses in the grand scheme of things, and this is a significant impact that it would make to prioritize folks with ALS. So let's get them on the list.
Thank you. We're gravitating toward the next topic, which is advocacy. Before we fully jump tracks to that topic, I wanted to make sure that we gave all of you an opportunity to address the particular question of the recognition of the urgency of caregivers also being vaccinated, along with people with in high-risk populations.
I think I'll jump in here because as we all know that the way they define essential worker or frontline worker, our caregivers for ALS patients are almost in that category because they are taking care of the patients, not in the community hospital setting or a clinic setting, but at a setting at home or in some other facility. So this caregiver should definitely be prioritized because that also prevents infection for our patients if they are protected. And so this is going to need some advocacy, but as we heard from Dr. Libby and other panelists, is that how we understand that ALS indeed is a risk factor, it indeed should be considered in the category of a high risk condition. I think that we can also extrapolate regarding our caretakers. I just don't know how we can bring that to the attention of CDC or ACIP, but that may be something we should work towards as organization.
Thank you. Dr. Libby, you were going to say something as well?
I was just going to mention that our state considers in-home caregivers to be Group 1A as healthcare providers. They are not professional, but in-home caregivers to patients who are homebound are considered in the same category. So they have been getting their vaccines in our state even before the ALS patients, and that seems a little unusual, but that's how it's going. And we have had a number of caregivers. I just saw two in clinic yesterday where the caregiver has gotten the first vaccine, the patient with ALS is not. But it's at least a start and a recognition that the caregiver is, and some of them go, from home to home, and some of them are just one patient. So it varies. But consider that in your state, you may qualify as a care provider in some states.
Thank you. Let's go ahead and move to the question of advocacy. We partially answered it already. One of the two things that we've heard already that are really critical is one, we've gotten a brief from Dr. Thakur as to what the ALS Association has already done or is currently doing by way of advocacy for better distribution and access for people with ALS and their caregivers. The other thing that we've heard is that because the system of distribution and access is determined in a very decentralized political system, state and local authorities are going to matter a great deal in this. So two questions. One is there anything else that the ALS Association and its partners are doing or could be, should be doing, or will be doing? And then the other one is, for those of us with ALS, well, we're very grateful for organizations speaking out on our behalf. We also sometimes really want to be active. What can we do as part of the advocacy program to increase our access as fast as possible to the vaccine, and where should we be targeting it? Should it strictly be at the state level, and if so, how do we go about doing that? Dr. Thakur?
Yeah, thank you. So a couple of things. So one, I think we are starting to get some data on outcomes of people who have ALS and also have COVID, and Dr. Galia's data, I think, is effective. So we can start another round of engagement based on that data to see what kind of case we can make. And I think that's Dr. Aurora Allegrini is texting me some strategies we can use to engage with them, and then also use our informal contacts with the registry, I think, to bump things up. The actual decision criteria that the CDC used was made by an advisory panel, and that process is not quite open. It's not quite explicit, and I think that's the opportunity for them to use their judgment in a fluid situation, which is a good thing. But we'll see what we can do on that, and we'll also consider if more letters in a broader sense is also going to happen, because states and counties are doing their own thing for their own reasons sometimes. I do want to say two things. The first thing is, we're talking a lot about advocacy and what people can do about getting the vaccine, but the most important thing people can do is maintain their infection control practices so they don't get sick. Even after you get the vaccine, it's really important that you work to not get people sick, because you may be not able to get the vaccine, but you may be able to carry it and transmit it. And so I would love our clinicians to talk more about that, because that's probably the number one thing is not get sick. And then the second thing is, when it does look like you fit into a category, I think we just need to go out and assert our right to be there. It's such a difficult, it's such a complex situation. You can't do a medical assessment on everyone. I think there's ability to have some flexibility there. And then on top of that, the overall supply of vaccine isn't what we want it to be. And I don't get the sense that there are, a lot of the folks are fitting into categories where communities have not gotten to yet in terms of vaccinating. So I'll stop there. There is more that we've done on COVID and conditions related to COVID and supply of ventilators and all, but that happened last year and it worked, and so I don't think we need to talk about it now.
Okay. All right. Well, let me toss your question back to the clinicians. This was also a question that came from the community. The question of prevention. Is there anything new that we need to know that can help reduce the exposure and infection of people with ALS and their caregivers?
Ken, this is Rick Bedlack again. Just answering this question, what I would say is I'm not aware of anything new. It's the masking and social distancing, but as I mentioned earlier, I mean, these have consequences. Yes, they do reduce the spread of the infection, but at the same time, we know that to optimize the care of a person with ALS, we need to see them in clinic and make measurements like pulmonary function tests. Those are the cornerstone of how we roll out evidence-based options to our patients. So it's a very difficult situation. And I just want to come back to the last question, what else can be done? We need more data. I mean, these two registries that we've heard about today are great, but they're very small and they have their limitations. And so I would love to see the ALS Association leverage its partnership with the National ALS Registry to do a very similar type of exercise that Dr. Galea did, where we look across not just part of one payer database, like part of the VA database, but across all the payers that the CDC registry has access to, so we can get a better understanding of the true incidence of COVID in people with ALS diagnoses and of what happens to them in the next 30 days. And that's the most powerful tool we have for answering a huge question like that. And this question is not going to go away. I mean, even if it turns out that somehow we can get the vaccine for people with ALS and their caregivers in the next phase, I mean, what happens next year? I know later on there's a question about, do we have to get a booster? I mean, we don't know, but I would say it's probably better than 50-50 that yes, the virus is going to mutate and we'll have to get revaccinated. So this is not going to go away. There's going to be the same problem again with prioritization. And so building a really strong scientific case about the risk for people with ALS is really important, even if it doesn't affect the very next vaccine phase.
Thank you.
So I appreciate that, Dr. Bedlack. I just want to make sure, when we use the term registry, we often mean different things. And so it can be what the National ALS Registry is about, which is counting people and trying to identify causes and environmental risk factors that can lead to ALS. Or it could be the work that Dr. Desai is doing, which is figuring out who's coming into clinic and collecting real time what's going on with them. And the two really aren't compatible. If we asked the CDC to do it and they went through Medicare has a 2-year delay, I believe, on billing records. That won't work. But what Dr. Galea is doing with actual clinical records out of the VA system, which is centralized, seems very promising. And I'm going to follow up with her over the weekend about that. So I agree with you, Dr. Bedlack. This isn't going away. We do need more data on how the progress of COVID and how we can treat COVID more effectively among people with ALS, and then we need to get that data to the CDC as fast as possible to see if they can give more guidance to the public health community. So there's some, I think, good news today that I'm learning, which is good.
We've got a bunch of questions that have been submitted by our listeners, audience, participants, and I don't know if we can get to all of them. We've got about 10 minutes. Let me start with a question about a comparative question from another country. There was a report out of Norway that suggested people with terminal illness should not be given the vaccine. What is the basis of that? Is that a widespread policy? And is there any concern about that spreading as a policy to the U.S.?
I'm happy to jump in on that. The reports I saw were mostly media reports on it, and there were 13 individuals that they looked at who were terminally ill. 6 were in very, very late stages, and 11 of them had significant comorbidities. And they did die not long after they got the vaccine. Whenever we have a new vaccine, we proceed with an abundance of caution. And so the Norwegian government decided, let's wait while we study the effects to see if this is happening anywhere else. The likelihood that the vaccine caused the death is very small. It's more likely that the person was very near death anyway. And so the other countries have not seen that. We've given the vaccine to many people. I have not seen data in the US that really stratifies, elderly at risk and then add in terminally ill as well. I haven't seen that broken apart, but we haven't found deaths associated directly with the vaccine in most of the millions of doses that we've given already in the US. So while I don't think anything significantly different is happening in Norway, they just saw this trend and wanted to be extra cautious to look at it more closely.
Thank you. We have a question from a caregiver about a person living with ALS whose appointments have now been all through telehealth and video calls with the physicians to lower the risk of infection both for the person with ALS and for the physician and his or her team. And the question is, how do we continue to do this while also, for both convenience and safety, I presume, while also making sure that our physician gets a much needed vaccine? which is nice because, you know, we tend to be preoccupied with our own health, but we forget that sometimes the people on the front line helping us are equally vulnerable.
Ken, I missed some of that question, but I think it was a question about how can we continue to use telehealth appropriately, protect healthcare providers, but also get all the information we need. And first, I'll say as a frontline healthcare provider that I greatly appreciate the thought that they want to protect us. I also feel fortunate as a healthcare provider that I've gotten my vaccine, so I'm at least partially protected. That doesn't mean I'm not going to wear my mask and not distance and wear the PPE, but I will do that. I think telehealth is here to stay. I think it's taught us a lot. I still prefer seeing patients in person, but that's maybe because I've been doing it for 40 years. But I've learned that I learn a lot about people when they are on their telehealth platform. So that will continue, and it'll allow us to get out into places and to see patients who weren't able to get into our clinic. So it provides an awful lot for us. Rick is really, Dr. Bedlack, very appropriately concerned about not getting pulmonary function tests. And we're working around that slowly but surely. And we've sort of defined who really needs it and who doesn't need it on a routine basis. Most of our recognized treatment centers and certified treatment centers of excellence have done every 3 months for most patients with ALS, doing a breathing test of one sort or another. And we've learned that we don't have to do it every 3 months in certain situations, depending on symptoms, where they're at with their disease and the like. So we're learning what we need and what we don't need. I hope that helps answer that question.
Thank you. That was very helpful. We have another
if
question.
you don't mind,
Yeah,
sorry, I just wanted to just shed something. The VA has been one of the first to start with telemedicine and adopting it. We've been using that even before the pandemic, especially with veterans with ALS, to minimize the traveling and the fact that the caregiver had to take the day off to come and see us. We're also working on a point of care handheld spirometers that we can actually give the patient so that we can have an idea of how the function test is in the home. So again, we're going to continue. I think it's a fabulous way to follow them, convenient, and quite frankly, keep us safe.
I'm just going to jump in here for one more thought that yes, it is really, really very important to have a very good information regarding the patient's pulmonary status by pulmonary function test. But again, because of the aerosolization and the risk of the spread of infection, that has been a difficult issue in taking care of these patients, which I'm sure has negative consequences. So we are in the process of doing a study, and I just want to bring it out there that the pandemic also has created this seismic shift in how we approach medicine. The telemedicine is probably here to stay, but at the same time, it has given us the opportunities to see what else we can do so that, and what other inventions we can bring in the practice so that we can take care of our patients. So there's one study we are looking at, and it hasn't yet started, but we are looking at the digital spirometry. So the patient can do the pulmonary function test at home while we monitor them. Our respiratory therapists can monitor them from the clinic, and we get real-time data more frequently. So we'll see what happens with that. But this has been getting attention in other diseases like cystic fibrosis and whatnot. So hopefully, stay tuned. Hopefully, we'll have some more information and we can turn some challenges into opportunities. And the same issue has been also with the clinical trials in ALS. We know that a lot of clinical trials in ALS depend on pulmonary function testing. And we also know that there has to be this tremendous scientific advancement by clinical trials for our patients to get the benefit of potential other treatment options. And so there has been a pretty significant pause in this trial. So that also has been a challenge, and we'll see how it all evolves in next few months or a year.
Thank you. We're running short of time, and I've got a few questions left that I think are really important. So I'm going to bundle all three of them together and ask for some quick responses, and then we're going to turn to Dr. Thakor for some closing remarks. The three questions are one from a caregiver whose loved one is apparently in a pretty advanced state, and the short question is, reading about the side effects, should he in fact get the vaccine, or could the vaccine be a greater risk than COVID at this point? Second, will the vaccine protect against the new variants of COVID-19? We'd all love to know that. And then a question that Dr. Bedlak anticipated, and that is, will the vaccine end up being yearly? Will we need a booster? The floor is yours, everyone. Short answers, though, please.
I'll take the second two. I'd let a clinician answer the first one. The good news is that the two vaccines that we're using now in the US seem to be effective against the UK variant, less so against the South African variant, so that's a concern. And we should have a third vaccine coming online pretty soon with Johnson & Johnson, which also is showing a fair degree of effectiveness against the variants that are out there. But keep in mind that the vaccines evolve as well, and so they're working on improving the vaccine so it will be protective against the South African variant. We don't know yet about the Brazilian variant, but the good news is right now the vaccines we have are working pretty well against what's circulating in the country. And we don't know yet if we're going to need it yearly. Most likely we're going to have a booster. Most likely the vaccine we're going to end up using the most is going to be very different than the one we have now because we improve them as we go along. So be prepared to get another dose in a year from now.
Thank you. Others?
Ken, I can take the first question. So, we really can't provide specific medical advice to folks unless we see them in our clinics. But what I can say for my own patients is I think the benefits of the vaccine outweigh the risks for just about everyone, no matter how far progressed their ALS is. The only exception I'm aware of is people who are known to be allergic to one of the ingredients in the vaccine, which seems to be extraordinarily rare.
Thank you. That's very helpful.
I would certainly agree with Dr. Bedlak. I might make an exception for a patient who's at the very end of their life, the last week or two or three on hospice, bedbound and the like. They may forego the vaccine at that point. But the side effects from the vaccine are so mild that anyone should be able to tolerate them. A low-grade fever, maybe, a little achiness, like when you get a virus and you feel sort of achy and chilly, those sorts of things. Beyond that, it's very, very rare. The anaphylaxis is only in patients who've had severe allergies before or have allergies to the components of the vaccine, which is extraordinarily rare. It's a lipopolysaccharide protective on the vaccine. So just about everyone would benefit from it. I think the risk is tiny, 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 and the benefits are enormous.
Thanks. Thanks so much. Thank you all. This has been extraordinarily helpful. We are all, as you can imagine, very hungry for information and advice on this complicated topic, and this helped clear things up a great deal. I'm going to turn the floor over now to Dr. Thakor for a few closing remarks. As you can see from the resources on the PowerPoint. Oh, there you are. I was just about to take you. The floor is yours.
Thank you. I just wanted to thank everyone for being on this webinar. ALS is such a difficult disease, but one of the wonderful things about being in this community is that there are clinicians and trustees and scientists who will volunteer their time on very short notice to get together to discuss an evolving situation. And this is a perfect example of that, and we do this often. I want to point out a couple of things. On this slide that you're seeing, we have ongoing up-to-date information on vaccine information, which is the top link. That we've done a lot of work on respiratory health, which is very important related to COVID. You get to see Dr. Menkhaus and Dr. Libby on a video series related to respiratory health, which was excellent. And Dr. Bedlak and Dr. Libby have done podcasts on connecting ALS, which are also really, really good. They help walk through all of these issues in greater detail. And I've learned a lot on this podcast. I think there's some follow-up for me over the weekend. I'm very excited about that. to see how the scientific community again comes together as things are changing quickly. Then to see if we can get the government to follow through. What I didn't mention earlier is the work that our advocacy community, I think Dr. Menkhaus was actually head of our policy committee at the time, to make sure that our non-invasive ventilators were not taken away. We got to keep that supply by some difficult work with Congress and CMS last spring, and so that went well. And we're making some progress with the CDC, and I'm hoping that we can make more progress soon. So thank you, everyone. Looks like we're over time.
Thank you, everyone.